Let me understand all the buttons here. Okay. I have no conflicts of interest to declare. I would like to start talking about some aspects related to the epidemiological data about TMD and migraine, which are a very important comorbidity. TMD is a common condition with a clear predominance in women, and what really stands out is that almost 50% of the cases progress to chronic forms. So migraine, on the other hand, represents an enormous global burden. It is among the leading cause of disability in neurological disease. And it's striking how early it begins, ranking first in children, in adolescents, and is still among the top causes of disability in younger adults. Another very important information here is that the comorbidity shows very early too, as we show in a previous study conducted by our group, showing that among children and adolescents we can already see it's not working well. Let's see here. Yeah. We can see the high prevalence of TMD, of migraine, the higher prevalence of migraine among children with TMD. So it's a very important comorbidity, TMD and migraine, and it appears very early in the life. So both conditions are frequent, are disabling, and disproportionately affect women, which makes understanding this, their overlap particularly relevant. So besides the cross-sectional data from cross-sectional studies, longitudinal research makes it clear that the relationship between migraine and TMD is bidirectional. The OPERA study, which is a large longitudinal project that has provided key insights into the epidemiology and risk factors for TMD, showed that having migraine increases the likelihood for TMD, especially when attacks are frequent. Other population-based studies with huge samples show the reverse association. Individuals with TMD are about twice as likely to present with migraine compared to controls, and this was consistent across different groups. And more recently, systematic reviews and meta-analysis confirmed this link, showing the association is particularly strong in chronic migraine. So we know that migraine is a complex condition involving multiple structures across both the peripheral and central nervous system, working in a network. And this helps to explain not only the pain, but the accompanying symptoms that we see. It's a wide range of different symptoms during the migraine attacks, and the psychosocial impact also. But today our goal is not to cover all these mechanisms. We are going to focus on CGRP and its role on the comorbidity. So the trigeminal ganglion connects the periphery to the brainstem with their cell bodies grouped in the trigeminal ganglion. When activated, they release CGRP in three places: in the meninges, causing the neurogenic inflammation; in the ganglion, where they excite neighboring cells and provoke ganglionitis; and in the brainstem, where they amplify pain signals. Normally, CGRP helps regulate sensory inputs, but when its level rises, this balance is lost, driving both peripheral and central sensitization in a feedback loop. That's why patients also experience other kind of sensibilities, hypersensitivity to light, sound, and touch during the attack. So CGRP arises as a possible molecular link between TMD and migraine. there are many receptors widely distributed in the trigeminal vascular system, and when peripheral stress increases CGRP release, it sets off pro-inflammatory mediators. This creates an inflammatory soup that amplifies signaling and excites all branches of the trigeminal nerve. Yes, the first branch of the trigeminal nerve has a special participation in the migraine. It's very well known, but we have to consider its role also activating the second and the third branch, and how special it is for the comorbid association with TMD. So CGRP can be detected both in plasma and in saliva, but each method comes with advantages and limitations. Plasma assays are more established, but CGRP circulates at very low and unstable concentrations. So we need to be extra careful to obtain reliable results. Another challenge is that plasma may reflect contributions from multiple tissues, not only the trigeminal source. Saliva, on the other hand, is much easier to collect and usually shows higher CGRP concentrations, which makes it promising for monitoring migraine phase or treatment response. However, there are still concerns regarding the saliva methods. So while both are useful, plasma offers methodological robustness, and saliva provides practicality and sensitivity. But more validation is still needed before either becomes a routine biomarker. So this is an ongoing study, which my team from IASP is developing in collaboration with Dr. Mario Perez, Dr. Malinenberg, and Dr. Hajar Jazin from the Karolinska Institute. And while CGRP has been studied separately regarding the TMD and participation on TMD physiopathology and in migraine, we still lack data from clinical studies that helps to clarify the CGRP role in patients presenting both conditions. So our main objective in this study is to investigate the role of CGRP in the comorbid relation between TMD and migraine, comparing salivary CGRP levels among individuals with women, specifically with TMD, migraine, isolated or combined. And also, we are collecting data regarding the clinical and psychosocial aspects, and we hope this will be very useful to help us better understand this collaboration. So we have very strict eligibility criteria, which bring lots of challenges, right? I'm seeing my students here. It's not easy to collect this sample because we included women presenting isolated or combined chronic myalgia, defined according to the DCTMD and ICOP criteria, and episodic migraine. We also included women free of any painful conditions in the control group. And here are our non-inclusion criteria, which were a particular challenge because we didn't include women presenting odontalgias, neuralgias, or other painful conditions. It's not easy to find these people. So we collected the saliva samples using a standardized stimulated whole saliva method. All participants provided their samples early in the morning while fasting, and they were instructed not to eat, drink, smoke, or brush their teeth beforehand. And to minimize contamination, they rinsed their mouth with water before starting. Each sample was collected over 5 minutes into sterile polypropylene tubes to protect sensitive peptides The tubes were pre-cooled and kept on ice, and the protease inhibitor cocktail was added immediately after collection. So the samples were then centrifuged to remove cellular debris. The clear supernatant was divided into small aliquots and stored at minus 80 degrees Celsius until analysis. Before testing, the samples were slowly thawed and centrifuged again, and salivary CGRP levels were finally measured in duplicate using an ELISA kit, followed the manufacturer's instructions. So this is Marlon Diaz, who's right here. Marlon just came from Karolinska, and I'm sure he will be more than happy to answer more details, right, Marlon? So, here is our sample flow chart until now. At this moment, data collection is still ongoing, as I said, so the data set is partial. Only a few saliva samples collected during migraine attacks, and those have already been analyzed. And here on the left are the first data we have collected during migraine attacks. Let's try this again. Here. And we see the four groups separately here. And as we can see here, the TMD group presented the higher concentration of CGRP, followed by the TMD and migraine, which was a surprise, actually. We were expecting the migraine group more with more higher concentration, right? The sample is, on the right here, we see the few samples we have already tested that was collected during migraine attack. So the sample is still quite small, right? But suggests that patients with both TMD and migraine may have higher CGRP levels than those with migraine alone. And these are promising first findings, but the broader picture will come when we integrate the molecular, the clinical, and the psychosocial data together. So for now, we can't explain or profoundly discuss the results because there are initial data, but there is evidence coming from other studies suggesting a dysfunctional CGRP signaling related to the comorbid TMD and migraine, and the comorbidity could potentially serve as an indicator of the likelihood of success anti-CGRP therapy, maybe for TMD also, but it needs to be tested. So I think many of us are familiar with this model, which expresses the migraine scenario, right? Showing that a large number of migraine patients are still not even diagnosed, right? And here it's important to consider that around 50% of headache patients present TMD, and the other way around is true also. So now think about how many of these patients can present in our offices for the orofacial pain specialists, the physical therapists, and the other professionals that work with patients presenting pain on the face and in the head. And also it's interesting to remember some data that Dr. Remy Burstein gave us yesterday. And he said that's an estimation that in Brazil we have one headache specialist for 76,000 people with headache. So, and this is not only for people underdiagnosed, but also about patients who are diagnosed but left untreated, or treated but not followed properly. Oops. So I think if you see this picture, you can say that we have a mission here, And I hope we will all leave this event convinced that there's a job to be done. So in conclusion, it's important considering the complexity of migraine and its comorbidity, and TMD is a very important comorbid condition. No doubt, finding biomarkers of the disease, which can also indicate the best treatment and the best time to prescribe this treatment, is undeniably important and a target for our research. CGRP could be one of them, and it indicates a path forward, without forgetting absolutely relevant factors such as the psychosocial, genetics, and the environmental factors. So I'd like to finish. Thank you for your attention. Thanks to my team from UNESP and from other parts of the world. And a special thank you for my previous tutors who gave me something very valuable and for whom I have eternal gratitude. So thank you. So now I'd like to invite Dr. Miriam Velly from Canada. Dr. Velly is an associate professor in the Faculty of Dental Medicine and Oral Health Science at McGill. She will talk from a presentation called From Acute to Chronic. What do we know about orofacial pain, progression, and headache involvement? Thank you, Doctor.
Okay, I'm very glad to be here. Thank you so much for being here in the afternoon. And I'm glad that we're not sleeping. That's a very good point, too. And I'm very happy to have this opportunity to talk about this association between headache and temporomandibular disorder. I don't have any conflict of interest and the study that I'll be talking today is funded by the Canadian Institute of Health Research. More specifically, I will be talking about, you know that there are many types of orofacial pain. There are many types of chronic orofacial pain. But today, I have only 10 or 15 minutes. Then I will be focused I will talk about temporomandibular disorder, okay? This is, I'm sure you know, it's a musculoskeletal condition, a group of conditions affecting the mastigatory muscles, temporomandibular joints, and the association structures, okay? And why I'm doing this today is because TMD is the most common chronic orofacial pain. And this sincerely is very shocking and surprising or frustrating, I believe, is to see that more than 30% of the patients continues to have pain regardless of the treatment that they receive. This is huge. Then, come on, if you have a persistent rate of 2% or 5%, to say it's okay. But more than 30%, what's going on? And this exactly is my job. I would say, if you ask me, okay, Dr. Velly, why? And my answer is that I do not have any idea. And I'm looking for that, and then I designed this study. This is a prospective cohort study to assess all the factors that contribute to the persistent pain, maybe the transition from acute to chronic or the persistence of chronic. And maybe I need to define acute and chronic because I noted today some different definitions. I'm using the definition based in the IASP, saying that acute pain is the pain that persists you have the pain for 3 months or less, and chronic pain is when you have this pain for more than 3 months. It's too simplistic. I understand this very well, and this is one of the problems. I'm sure that we need also modify this classification. Then I'm completely sure that causes misclassification, but we can talk about this after. Then this study here, you see that some photos of Dr. James Fricton and Dr. Eric Schiffman. I worked in Minnesota for a few years, and I was very happy to be there. And we assessed there the factors that contribute to the persistence of chronic pain. You see here the time, 18 months, is huge. And in this study, we found that fibromyalgia, and depression contribute to the persistence of chronic pain. You don't see headaches here, but we just see that we have fibromyalgia is a type of orofacial pain, sorry, a type of chronic pain. After that, what we did, we decided to look for acute pain. What do you know about acute pain? And we did a review, and I was extremely surprised to know that I just found 2 studies, prospective study design that assess the factors that contribute to the transition from acute to chronic. If you go to chronic, you have many studies that assess the contribution of chronicity. Also, but if you go to other types of pain conditions, for example, pain after surgery, you can find many studies. But about temporomandibular disorder, about orofacial pain, you don't have. And this sincerely surprised me a lot. But I'm just showing you this study because I like that you see here that we have 2 studies. And this one study from Epicar and another study from Garofalo. The study from Epicar here, you see that he found that muscle disorder was associated with the transition from acute to chronic. But I do not know if you understand very well epidemiology. And this OR means odds ratio. And when you have an odds ratio lower than 1, is that you have a protection. It not increase risk. The meaning that if you have the muscle disorder, you have a protection. And this is a little bizarre. Okay, and I thought, okay, what's going on here? And another thing is, if this study also found that characteristic of pain intensity, also, if you have a severe pain intensity, characteristic of pain intensity is the average of pain intensity, current pain, worst pain, and pain now, divided by 3, multiplied by 10. This is the part of the Great Chronic Pain score developed by Van Korf, okay? And I use this a lot to assess what's going on with the pain. But again, this is very bizarre because if you see here the odds ratio is lower than 1 again, and what's going on? And if you compare with pain after surgery again, you see that pain intensity increase the risk. It do not decrease the risk. Now, if you go to the study from Garofalo, you see that muscle disorder now increase the risk. Exactly the opposite, okay? And they are from the same university, same team, Epicar and Garofalo. And in this study, pain intensity, again, you see the odds ratio lower. The 1 means that you have a protection. And this didn't work, okay? I thought, what is going on? We need to investigate this further. And then we conducted a prospective cohort study, and we found here that characteristics of pain intensity contribute to the transition. And you see that now you have an odds ratio greater than 1, means that you have increased risk. You don't have a protection. Then this makes sense. And also we found that sex, someone who have a presentation in the past about sex, we found that sex also contribute to this transition from acute to chronic pain. But during this study, we found that many patients complain of headache. Many. Again, I'm not saying that's migraine. I'm not classifying the type of migraine at this moment. I'm just mentioning that headache was self-reported. And we conducted a review. We found that the prevalence of headache among patients with TMD exactly as was reported just now is very common. 9 to 97% is huge. And also we found that when you compare with controls, you see that individuals with TMD, they are more likely to report headache than controls. You see here the odds ratio. It ranges from 2 to 8.8. I'm completely sure that we have here selection bias, information bias we always have in epidemiology and self-report. But when you have these huge numbers, odds ratio like 2 to 8.8, is because you really have something here. And then we decide to look, okay, what is the contribution of headaches in this persistence of pain or transition of pain? Then in these studies, all the patients receive the diagnosis based in the DC or RDC. They completed the questionnaires are recommended by the International Network for Orofacial Pain and Related Methodology as recommended. Okay, then the data is it's there. And this is what I found. We found that we recruited a number of patients acute pain. We have here number 104. Again, acute pain means that this patient reported pain for 3 months or less. Okay, and also we recruited patients with chronic pain. They have pain for more than 3 months, and the sample size was 308 individuals. And then the baseline, we collected all information about the headache, and these individuals were followed for 3 months. Okay, because it's a prospective design. A prospective is a follow-up study that we recruited. We have a data at the baseline, and we do the follow-up after a specific time. And after that, see here that the transition rate was 58%. It's huge. You see that individuals that they have acute pain at the beginning, we ask them if they had pain based on the characteristic of pain intense at 3 months of follow-up, and we found that 58% of them reported they had pain. And again, and this is, I don't say sad, but say what's going on, we need to help these patients. And see now that the persistent rate was 62%. I should use that, again. And I'm not. Anyway, you can see here the numbers, 58% and 62%. These are huge numbers. And now we need to see what's going on. And we are looking for many factors that contribute with that. I showed you before that pain intensity affect. And now here I'm looking for headaches. And this is what we found. Again, I'm showing you the odds ratio. Odds ratio is the likelihood to have this condition when you are exposed to, in this case, headache. And this is a prospective analysis, and I calculate the risk, not really the odds. Okay? And we see here that when we consider the outcome as transition or persistent at 3 months of follow-up, we found that individuals exposed to headache, they have increased risk to have the transition or persistence. Okay? You see here the odds ratio 1.9, and see the confidence intervals 1.2 and 3.5. After that, what we did, we decided to stratify the analysis. Okay? Only considering the transition outcome, and another one only the persistent outcome. And again, if you see here, we don't have statistically significant results. However, I really recommend you always look for confidence intervals in the magnitude of the effect. See here that the transition risk is 1.9. It's very similar to the other one, that is 1.9 when you consider transition and persistent together. See the confidence intervals, 0.8 to 4.1, suggesting that, yes, we have something, but probably we don't have the significant because we don't have sufficient power, okay? But again, we can talk about statistical analysis after. I really think that headache here is associated with the transition because of the magnitude of the effect and the confidence intervals. And when you go to persistent here, you have an odds ratio a little lower, 1.5. And when you have, again, if you have an odds ratio like 2 or 4, easily you can find a significant result. But when you have an odds ratio lower, it's more difficult. You don't have too much power, and you need to have a greater sample size. After that, when we use this questionnaires, we always ask, where do you have the pain? Again, this is self-reported. And the patient report, oh, I have a pain in my top, behind my eyes, something like that. And see what we found. we found that pain at front of the head was not associated. See, the magnitude of the effect is very low, 1.3, okay? And the top of the head was associated. The magnitude is 2.7, and you see here that is significant. The confidence intervals is 1.4 to 5.4. Then you have something in there. Similar to back pain when the patients report they have pain back in the head. And I was very curious about behind eyes. And I was thinking all the type of pain. I was thinking comorbidity, cluster headache. I do not know. I was trying to understand these findings here. But this find showed to me that we have an association with transition or persistence, okay? And after that, we need to look only for transition and only for persistence. These are the findings that you can see that transition, unfortunately, is very common. It's 58%. Persistence, transition and persistence are very, very common. Also, we found that headache is associated with the transition or persistent. But again, I'm repeating, if you see the confidence intervals, our findings suggest that is really associated with, specifically with transition. Okay? After that, we found, I'm just repeating just to memorize, that different types of self-report of pain, the top of the head, behind the eyes, etc., are all associated with this persistence of pain. Now, and as epidemiologist, I always need to explain that this is not a survey, it is a prospective study design, and everything was self-reported. Then we have a chance for misclassification, okay? And a big limitation is that at this point, I just adjust for sex and pain intensity. There are many other variables that need to be adjusted. For example, treatment. You can say, okay, but what kind of treatment this patient receive? It's an excellent question, but I could not yet adjust because we have so many variations in the treatment that we don't have sufficient sample size to add this variable to the model, okay? And however, again, this is a prospective design, and the prospective design is the best observation study that we have. The best one is clinical trial, but when you have the observational design, the prospective is the best. And its best point, the baseline data that you collected, the error that you have at the baseline is independent of the error that you have 3 months after, okay? What happens if you have independent misclassification? Your magnitude of the risk decrease. Then we say this is a non-differential bias and your magnitude of the risk decrease, okay? Means that what we found appear that really have, but we just need to have increase a little bit more the sample size. Just to finish, I would like I will just talk about headache, but again, it's self-reported, and it's possible that we have another variable that is associated with headache and is also associated with TMD that bring all this transition and persistence of pain. And we are looking for that too. Okay, then I'll just show that. Then this conclusion is that headache is associated with transition from acute to chronic pain, and we need to really increase the sample size, collaboration. If you don't know my email, I'll be very glad to give to you. And I love exchange and suggestions, okay? I'm always learning a lot when I hear some comments. Thank you very, very much, and thank you.
Thank you, Dr. Velly. Now I would like to introduce Dr. Simon Akerman, who is from UK, but works on US. He's an associated professor and vice chair of neural and pain science at the University of Maryland, Baltimore. And his presentation is TMD, myalgia and headache, pathophysiological mechanisms and clinical implications. Thank you.
Thank you, Dr. Gonçalves, for the introduction, and thank you for the organizers for inviting me today. So my title says TMD myalgia. I've expanded this a little bit to cover all muscle-related TMDs. I think myalgia is probably a little bit limiting, and it says headache, but it'll probably largely focus on migraine-related headache, mostly because, as we've heard so far, there is a strong overlap with TMD and migraine in particular. I'm going to dig into some of the pathophysiological mechanisms, so there's going to be some animal data here, and what are the clinical implications of this. These are my disclosures, nothing particularly related to what I'm going to talk about today. So I'm just going to start off with an overview of the very basic mechanisms as we understand it from the perspective of migraine headache and associated cranial symptoms. This is a headache audience. I'm sure most of you are very familiar with this already. So put simply, we believe that migraine headache and the cranial nociceptive symptoms are a consequence of activation. I'm just simply, oh, that's how you do it. Okay. Migraine-related headache and cranial nociceptive symptoms are a response of activation and sensitization of peripheral and central durally innervated trigeminal vascular neurons. So those neurons which, this is not the easiest to use, which projects up to the dural vasculature, but also projects centrally to the trigeminal cervical complex. And this is responsible for mediating the headache, the throbbing quality of headache, but also some of the associated craniofacial symptoms. So intracranial hypersensitivity seems to be responsible for some of the exacerbated symptoms with physical activity. So the fact that patients report that they would probably rather stay still than move around because the symptoms are exacerbated by movement. Extracranial hypersensitivity, so consequences of central sensitization, are thought to mediate things like cutaneous allodynia. So allodynia in the referred pain region, but also the fact that it can transfer to the contralateral side of the headache. Then we bring in some neurotransmitters. We've heard a lot about CGRP already today related to migraine, and this is also largely related. I think most people are familiar with the durovasculature innervation, but this is also relevant to central structures as well. But there are other neurotransmitters involved: PACAP, VIP, nitric oxide, and inflammatory mediators, prostaglandins, potentially cytokines. And as I say, whilst these are predominantly thought to be related to the durovascular input or projection, there is also a role of these in central related mechanisms, which is where we come to central activation. We know there is activation in the brainstem and diencephalic structure. So we have the RVM, parabrachial nucleus, the PAG. We've heard a lot about the hypothalamus today, and these aren't just a consequence of pain activation and the consequence of nociceptive activation, but actually there is activation present before you even have head pain, which suggests that actually this activation precedes meningeal activation in this situation. We also have, of course, thalamocortical mechanism. So it's a very 1 minute overview of what we understand of migraine and headache to some extent mechanisms. Temporomandibular disorders, I'm not going to go into too much detail. This has been sort of overviewed already today in this session, but musculoskeletal and neuromuscular conditions involving muscles of mastication, temporomandibular joint and associated structures. The most prevalent and painful TMDs of those of muscular origin. So we're talking about myalgia and myofascial pain, but of course there are joint-related arthralgias. Now we commonly talk about TMD in relation to the V3 mandibular division, but there is of course referral to other trigeminal divisions in this situation. When we talk about mechanisms of temporomandibular disorders, obviously there is a series of symptoms related to this, but I'm going to try and sort of put this into very simple terms. So the muscle-related TMDs, which is what I'm going to talk about. So myalgia, this would be more like localized pain. If you were to palpate the muscle region where the pain is being localized, possibly in the masseteric or temporalis muscles, this is likely mediated by localized inflammation and perhaps to some extent peripheral first order sensitization, which is what you can sort of see in this illustration here. When you move on to myofascial pain, we're talking about the area being palpated where the pain spreads beyond the site of palpation but within the same muscle structure, and this is very likely mediated by peripheral sensitization here. So activation of the peripheral projection to the musculature itself. When we move on to myofascial pain with referral, we're talking about going beyond the muscle boundary of palpation to perhaps associated areas. And so maybe in this case, we're talking about the temporalis muscle, and this is likely mediated by central sensitization, because you're talking about an input that is sensitized from the inflamed musculature that is mediating a response in an adjacent muscle that is not necessarily inflamed itself. And so there is a convergence of these inputs onto this central region. This is likely mediating some associated symptoms, so pain with mastication, limitation of opening, but interestingly, headache as a symptom of temporomandibular disorder specifically. We've heard a lot about the neurotransmitters, and Dr. Gonçalves has talked about CGRP. I don't want to go into too much detail. I do want to highlight one study by my colleague here, Dr. Marcela Romero Reyes, who did this study some 10 years ago now, where she developed an animal model where you inject an inflammatory mediator into the masseteric musculature, and you observe certain behaviors, some nociceptive or pain-related grooming behaviors in these animals. When she gave a CGRP antagonist, she observed that these nociceptive-specific behaviors were attenuated. They went down, suggesting that there was some level of analgesia, supporting a role of CGRP in these mechanisms. She also observed neuronal activation, which was again attenuated by these CGRP receptor antagonists, which supports some of the early data of Dr. Gonçalves that there is a CGRP-ergic mechanism. Is it local? It's possible, but we see a neuronal change as well. So potentially, like we see in migraine headache, that there may be a neuronal mechanism related to CGRP activation and targeting in this situation. So this sort of took us on to the idea of looking at CGRP, and this is where we're going to dig into some mechanisms. Looking at the role of CGRP in the effect, and this is my background coming from a sort of neurology headache background, of the role of CGRP in potentially mediating or having a role in headache attributed to TMD. And so we sort of adapted this behavioral animal model and used what is my core sort of technique, which is using electrophysiology. And so we sort of merged these approaches. So we recorded neurons in what we've termed as the trigeminal cervical complex, or the sort of trigeminal upper cervical region. These neurons were characterized as headache-like or intracranial headache-like, as having both an intracranial input, so here we see we're stimulating the meninges, and an extracranial input in the cutaneous facial receptor field in and around the eye. And then we injected CFA into the masseteric musculature. The first thing you'll see is that we are switching these neurons on. We're switching these neurons on in a significant, a significant population, around 65% of the neurons that we record from, but we're seeing activation in this neuronal population. We also see intracranial hypersensitivity. So when we stimulate the intracranial neurovasculature, we see an increase in neuronal response, and we see an extracranial neuronal hypersensitivity here. Now, when we used a CGRP receptor antagonist in this assay before we give the CFA, we can see we are absolutely preventing any of the outcomes that we observed with CFA on its own, suggesting that there is a strong CGRP-ergic mechanism to this. So what we're seeing here initially is that you inject something into the masseteric musculature here. You are mediating a response of neurons which are being innervated by the neurovasculature. So there is a convergence of inputs, and we also can see that there is a strong CGRP-ergic mechanism to this. Now, when we sort of put this together and look at perhaps what is shared between these two systems and what is shared between these two pain disorders, well, we can see central sensitization is key to this, central sensitization of the trigeminal system. It's the one thing which we know is completely shared by these two pain disorders. We generally refer, when we're talking about migraine-related mechanisms or intracranial mechanisms, as trigeminal vascular, because their trigeminal neurons are richly innervating the dural vasculature. We've heard a lot about CGRP. There is a strong link with CGRP between migraine and TMD, or certainly many headaches, but migraine in particular, and TMD. But also it's worth noting some of these other neurotransmitters. The PACAP, VIP, strongly associated with migraine. Substance P, perhaps less so with migraine, but it's strongly implicated with TMD, or other inflammatory mediators, prostaglandins, cytokines. possibly involved in some of the mechanisms related to this these disorders separately, but potentially the overlap, which leads me to sort of where I want to go, is looking at, well, does these shared mechanisms contribute to the overlap of these pain conditions or their comorbidity, as we've heard about? And if they do, how is it doing it? And this is where we sort of move on to some of the mechanistic things. I won't go over this slide in detail because much of this work is done by Dr. Gonçalves and her research team, but suffice to say, migraine is comorbid with TMD. They're more likely than chance to occur together. They increase the prevalence of each other. Symptoms are exacerbated when they occur together, and particularly if you have persistent or chronic TMD, you become far more likely to develop chronic migraine. So it's a risk factor, and one of the markers for this, cranial allodynia, work done by Marcelo Bigal and his team many years ago, now showed that if you have increasing symptoms and more severe symptoms of cranial allodynia in migraine, this increases the likely chronification. And so if TMD comorbid with migraine increases the likelihood of cranial allodynia, this seems to be a marker of that. And so we sought with my colleague, Dr. Marcelo Romero, to see, well, can we model this in an animal model, and can this help us understand some of the mechanisms involved? And so we kind of just put two models together. We used the CFA injection into the mesenteric musculature as our TMD-like model, and we used CGRP. We were interested in CGRP because of all the work which had come previously with this, and we thought this might be a link with this. And so we combined the approaches. We gave an injection of CFA, and we infused CGRP into our rodents and looked at the headache-like responses, the intracranial headache-like responses. The sort of the two lines which are in sort of parallel with each other are the responses of CFA or CGRP on their own. So you can see that there is activation and sensitization here. So they're mediating the responses which we thought. When we put the two together, though, firstly, you can see there is an exacerbated phenotype. There is more activation over and above the individual items, and so you can say, well, perhaps it's additive, that is possibly a consequence, but it's certainly exacerbated. But we also see this in every single animal we record from, rather than a subset, which is what we see with CFA on its own, or in fact what we see with CGRP. We now get a response with every single neuron that we are recording from, suggesting that we are making it more likely with a TMD like episode in our animal that they will respond to a CGRP molecule. And you might say, well, if you put 65% plus 65%, you're more than likely to get all of the responses. Well, statistically, it's going to be about 80%. You should get some attrition, but you're seeing this effect. We also, of course, see the manifestations of central sensitization, intracranial and extracranial hypersensitivity that is again exacerbated. So translating some of the clinical phenotype that you see in this comorbid condition, and we can also see an expansion of the cutaneous facial receptor field in our rodents, suggesting again that there is central sensitization signatures and an exacerbated phenotype. So that suggests that CGRP may be involved in this comorbid mechanism. We wanted to look at this in a slightly different way. What happens if we have CFA on board for a little bit longer? If you give it and look at the responses after 3 hours, it's more of an acute effect. But we want to look at more persistent TMD-like outcomes. So we injected CFA and then we waited 7 days to see what the outcome is with a more persistent inflamed phenotype. We also changed a few things around. Rather than focus on CGRP, we used something which is more commonly used as a migraine provocative, nitroglycerin in this situation. And we changed something again. We used a dose of nitroglycerin in rodents, which does not normally mediate a nociceptive response. So if you see the black lines here, this would be the response. Oh, you can't. This would be the response to 1 milligram per kilogram of nitroglycerin, which is a large dose for humans, but a relatively non-noxious dose in rodents. And we can see it's doing nothing here. And the first column in the bar charts, it's doing very, very little. But when we put this together with the CFA, we can see a slightly different outcome. So we inject CFA, we wait a week, we do a low dose infusion of nitroglycerin. We can see. So this is CFA on its own. In grey is nitroglycerin at the normal dose. And when we combine it, CFA, with the 1 milligram per kilogram dose of nitroglycerin, we can see, well, it's certainly switching it on, but it's again an exacerbated phenotype. We can see this extends itself to the intracranial and extracranial manipulation, suggesting that there is central sensitization. And we also see this in every single animal that we try that. every single animal that we record from. All of the rats are responding in this scenario. So not only are we increasing the likelihood that these animals respond, but we're actually reducing the threshold necessary to mediate a response, which is what you potentially see in the migraine patients. They become far more likely to have a migraine attack, and perhaps with a lower threshold necessary to provoke this. We replicated this using a behavioral approach. So here in our rodents, on the left is a rat, and on the right is a mouse. We probed the periorbital region with these fine filaments, and when they brush the filament away, it's suggestive of a hypersensitive response. We can see in red, CFA on its own mediates a unilateral response on our rodents, just the side of the injection. In grey is nitroglycerin, the high dose, and we can see it means a bilateral hypersensitivity. But in blue, we can see the animals which receive CFA, waited a week, we give nitroglycerin at a low dose, and we can see its mediating effect again in these animals. So it's reducing the threshold to mediate a response, but it's mediating it on the contralateral side. So don't forget, non-noxious dose mediated on the contralateral side, and we can replicate this in the mouse model as well. The red and blue is the response to CFA on its own, and green and grey is the comorbid condition. So when you put this together in a sort of clinical scenario, if you take the situation of the presence of TMD myalgia, so you have a localized inflammation, some level of peripheral sensitization in the V3 related region. Persistent TMD may mediate central sensitization and myofascial pain, perhaps with referral. Now, we have this situation where we have persistent central sensitization, which can potentially mediate a latent sensitization of convergent inputs coming in from the intracranial dural vasculature here. When we bring in some migraine triggers, perhaps ordinarily, certainly speaking for myself, perhaps one trigger which might, people talk about triggering migraine, stress, might be not sufficient to trigger a migraine, sleep deprivation maybe on its own not sufficient. But in this latent sensitized state, you throw in one migraine trigger here, or you could even provide a low dose of a provocative agent. It now is sufficient to mediate this response of these convergent inputs which are responding to this latent sensitized state, thus creating this situation where the migraine patient is far more likely to respond, and there is a much lower threshold to mediate this effect. I suspect I've gone over time here, so I move on to my final slide. Just to say thank you, and just to bear in mind that this convergence seems to be key to what we're doing. I want to thank the people who I work with. Dr. Romero is sort of the driver of this comorbid research that we're doing from all of her experiences in the clinic, which we try to put together in the lab. Our team of scientists, and particularly I want to highlight Dr. Daniela Salvamini, who is a pharmacologist and is providing us with some unique opportunities to dissect some molecular mechanisms related to this comorbidity, and these are our funding agencies here. So with that, I will thank you for your time, and I'm not sure if we have time for questions, but if we have, we can do it. Thank you very much. Thank you very much, everyone.
So thank you for your presence here. We don't have time for questions, but you can reach the speakers around. And thank you. Thank you for you.